Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. We're here with a very, very special guest today, Dr. Linda Nguyen. Thank you so much for joining us, Dr. Nguyen.
Thank you for having me. I'm excited to join you.
We're excited to hear a little bit about your work as a gastroenterologist, obviously, but your work in supporting gastroparesis patients and ensuring that patients that are suffering get great treatment. Before we jump into that, we'd love to hear your story about how the GI realm kind of brought you in and your interest in gastroenterology overall.
Yeah, so I'm someone who loves food, and the idea of having individuals out there who cannot eat or who suffer from eating or after eating is really heartbreaking. And it goes back to my mother. So when I was in undergrad, she was diagnosed with gastric cancer and had surgery. And she eventually passed away from the cancer. But during her years of therapy, the hardest thing for her was she couldn't eat. And it affected her in such a way, not just nutrition, but the ability to socialize. And because food and eating plays such a huge role in everything that we do, that's why I'm passionate about trying to help people, not necessarily cure digestive disorders, but help people be able to manage their chronic disorders.
Yeah, I imagine it can be very tough. I personally haven't had to deal with that type of challenge, but I know that gut health plays such an important role in our overall ability to function. And we know how social lives are tied so heavily towards food and just that experience. So it obviously having happened within your family is a great way to kind of prompt you to go in that direction.
Yeah, I have a saying that I like to say when I was really interested in wines and good wines. We used to go out and we would talk about the fact that in order to live, you need to eat. But in order to really love living, you need to love eating. And so anything that would sort of take away from that would be something, especially if it's a loved one, would be really distressing. So I could see that as a really strong motivation to go into the field. So that's a great intro to why your focus is where it is, which is on gastroparesis. Can you let our audience know a little bit more about what gastroparesis is about, and what causes it, and what the people go through when they're experiencing it?
Yeah, so gastroparesis is the paresis part means paralysis, but the reality of it is that the stomach isn't paralyzed, but it's not functioning appropriately. So there's slow digestion, slow emptying. And the most common symptoms are nausea, vomiting, fullness, so early satiety, feeling really full after a small meal, abdominal pain, bloating. But the real cardinal symptoms are, nausea and vomiting. The most common cause, if we can call it a cause, is idiopathic gastroparesis, meaning we don't know what the cause is. And then, diabetes is the second most common. And we see in neurologic disorders like Parkinson's disease. More and more, we're recognizing post-infectious causes of gastroparesis. So after viral gastroenteritis, Epstein-Barr virus, we're seeing gastroparesis after COVID infections, independent of the severity of the COVID infections. So there's the post-infectious cause of it. So as we learn more, we're going to find more causes, and I think that bucket of idiopathic will get smaller and smaller. But right now, the most common are idiopathic, diabetic, and then I forgot to mention post-surgical. So surgery that can potentially injure the vagus nerve. So common ones are anti-reflux surgery, like fundoplication, for like heart or lung transplant, open heart surgery, any thoracotomy, so any chest surgery that can potentially cause injury to the vagus.
I would imagine anterior spine surgery also, where you have to mobilize the enteric nervous system and the intestines. Anytime you're mobilizing that, you're disrupting that really important enteric nervous system, and that can almost be like is it almost like a post-operative ileus that just never resolves in this case of surgery?
Not necessarily post-op ileus, because with ileus we think of it as more of a small intestine dysmotility, or colonic dysmotility. This is really isolated to the stomach, and it's not necessarily transection of the vagus, because then you would think more if there was complete transection that you would get dysmotility more distal in not just the stomach but the small bowel and the colon. The vagus innervates the GI tract essentially from the esophagus all the way down to the right colon. So anything that affects the vagus can affect the entire GI tract. And I think we tend to think of the vagus in terms of the motor or the efferent activities, but we forget that there's a huge sensory component. So even if the motor function is normal, having vagal dysfunction or dysregulation, injury, however you want to term it, can be seen as normal motor or motility function, but abnormal sensory.
So is that why we see, and I learned this some of it from you when we worked together years ago, is that part of the reason why it's not really clear on tests to see that the stomach isn't functioning properly, or that food isn't moving at the same pace, and yet they're still having dramatic symptoms. So we call it gastroparesis, which suggests, the stomach is paralyzed. But the actual transit time, it might be slower on average, but it's not dramatically different from normal. And as a result, it isn't really, as you said, the motility problems. It's a sensory issue. It's the afferent fibers, the fibers that are bringing information back up to the brain, where the brain may be just misunderstanding, misperceiving what those signals are supposed to mean.
Well, I think part of it is that gastroparesis is heterogeneous in terms of the pathophysiology. We dump everybody into this diagnosis of gastroparesis. And I kind of equate that to heart failure, right? So congestive heart failure, we have systolic dysfunction, diastolic dysfunction, valvular heart disease. And we treat those differently because we classify them differently. And the stomach has, the fundus, or the upper part of the stomach, is supposed to relax, and that's actually under vagal control. So I think of that more like diastolic dysfunction. So if that part's not working, you can have symptoms, but the gastric emptying or the ejection fraction looks normal, but there's a problem with the filling of the stomach. And then, of course, the actual gastric emptying part is that systolic dysfunction. So there's something wrong with the contractile activity, but that may be because there's obstruction at the level of the pylorus, or that there's dysmotility of the small intestine. So if you have small bowel dysmotility, it's not able to accept the food that's coming out of the stomach. But we dump all patients with delayed gastric emptying into a singular diagnosis of gastroparesis, which is why we often see that normalizing of the gastric emptying does not necessarily correlate with normalization or resolution of symptoms.
That's a great analogy. That analogy to the heart, and as you're talking, it seems like it's really, there's two separate groups. One group has I'm going to probably get this wrong, but one group has sort of a sympathetic overdrive, and the other group has a parasympathetic problem. And so the two things may produce similar symptoms in the way you feel, but they're really doing something fundamentally different. And so that's a very interesting way of looking at it. Does it make one group of people more, I won't say susceptible, but more responsive to certain treatments versus another group?
So we do see, autonomic dysregulation in patients with both diabetic and idiopathic gastroparesis. In diabetes, we see more of, an autonomic neuropathy, so more widespread. In idiopathic gastroparesis, it tends to be more of a dysregulation, as you say, some with, abnormalities in the sympathetic nervous system, others in the parasympathetic. And we haven't gotten to the point where we can personalize the therapy, saying, okay, you have high sympathetic activity, and so we need to give you a therapy that's going to decrease that. Or you have a problem with, parasympathetic excess or hypo parasympathetic function. So, one of my visions, and JP, I think we talked about this years ago, was that it would be great if we could, measure those and characterize people and show that if you have this signature, then this group of therapies will work for you. Right now, where we're at is more, symptom-driven treatment. So if it's nausea, we treat the nausea. If it's pain, we treat the pain. And I, this is my personal belief here, is that I think this is why we haven't had a new FDA-approved therapy for gastroparesis in almost 40 years. I think what was it that I said? I think in the 1970s was the last, metoclopramide was the last FDA-approved therapy for gastroparesis. And we know metoclopramide isn't great. There's an FDA black box warning for it, limiting it to 12 weeks because of the risk for tardive dyskinesia. And a lot of patients, by the time they come to me, they've already tried it. It either doesn't work or they've had side effects from it. I'm not saying that, it doesn't work for everyone, but because of the lack of therapies, there's this huge unmet need out there, and patients are suffering. And I think that the other difficulty when there are limited therapies is when doctors don't know what to do. We do what we're great at. You avoid, right? You're like, you've got gastroparesis. I don't know what to do with you. Go to an academic medical center. But there are limited academic medical centers that can help take care of patients. So we need to, have more therapies accessible to patients that are safe, that then, gastroenterologists in the community and even, primary care doctors or endocrinologists, neurologists will be comfortable prescribing or providing these therapies.
It's very similar to a conversation that I had with over at Oxford University with Zam Cater, a headache specialist, where we talked about the fact that the state of headache treatments is really very similar, maybe only just an inch beyond where gastroparesis treatment is, in that they're still treating and classifying patients based on symptoms, as opposed to, the next level up would be responsiveness to different therapies. They've got one at this point. They've got a treatment for hemicrania continua, which is using indomethacin. And it's an indomethacin responsive headache. They actually classify it that way, indomethacin responsive headache. But a lot like metoclopramide, you've got the same problem with indomethacin, in that if you continue to use it for too long, you're going to get an ulcer. It's going to burn a hole through your stomach. And so you can't stay on the therapy very long. It works for almost all patients, but they can only use it for so long. So, getting back to, the next level of sort of cutting things up would be understanding the root cause. And that's really, to me, sort of the highest level of understanding. And I think from what you're saying, I'm feeling like there's an opportunity here, because sort of what's happening in diabetic patients. But in this idiopathic group, you mentioned some infections and prior surgeries and other things. How about some emotional traumas? Because what you're talking about here are things that would activate the immune system systemically in a way, especially COVID. We know how systemic that inflammation can be and how prolonged it can be. Same thing with a major surgery. Are there other things that cause major immune responses, like emotional or mental or sleep loss, that can actually cause prolonged periods of inflammation that might end up leading to this sort of manifestation of it, which would be gastroparesis? Do you have patients in your intuition after doing this for, I won't date you, but for a few years, have you sort of picked up on that as a confounding factor that needs to be sorted through?
Yeah, so that area has actually been studied well, mostly in the irritable bowel world, but we do see this also in gastroparesis and functional dyspepsia, that early childhood trauma is associated with a greater risk of developing motility disorder, or irritable bowel is classified as a disorder of gut-brain interaction, or DGBI. So having prior childhood trauma increases your risk of developing one of these disorders later in life, and it's associated with more severe symptoms and worse quality of life. And there was a really elegant study that was done at UCLA in IBS, where they found that just talking about the trauma, to not necessarily to a specialist, but a friend, a confidant, helped to decrease the severity of symptoms. And so we do see a lot of patients with PTSD, with anxiety, depression. Now, when it comes to anxiety, depression, it's hard to know what's chicken and egg, because if you're chronically ill, you can't eat. You're not getting the care, you're experiencing stigma. And we conducted a qualitative research study where we found that patients with gastroparesis, experience a significant amount of stigma, not only from friends, family, colleagues, but also the medical system. So if you kind of take all that together, anxiety, depression, it's almost like, who shouldn't? Why don't you feel this way? What's going on? Because there's all these, physical, mental, emotional things that you're trying to deal with. So, but we do definitely see, higher rates of PTSD. And I think we're also starting to recognize medical PTSD. So the trauma that is experienced by patients at the hands of people who should be helping them.
This is really interesting because it ties in with the polyvagal theory of safety and driving a strong vagal response, a strong parasympathetic response when we feel safe, when we feel comforted, when we feel emotionally capable and not vulnerable or under emotional stress. And what this does is, when we are in a space or a feeling of lacking safety, it pushes us initially into a sympathetic overdrive or a sympathetic state, theoretically, of course, but we can see it with the number of conditions that somebody is experiencing and the severity of those symptoms as they increase. And what it can also drive you into is what Dr. Stephen Porges, the inventor of the theory, came up with or coined, was the dorsal vagal response, where we go into a freeze response at the most severe range of this. And so the idea of talk therapy, just being able to get these emotions cleared out of the internal kind of workings of the person, allow for symptomatic improvement very clearly, because it's driving that feeling of being safe and being able to talk about these issues. And that helps to really drive this physiological response to a psychological trauma that may have occurred in the past.
Yeah. And it's not to say that this is purely, psychological, because I don't want people to walk away to say, okay, gastroparesis is in your head. It really, there is a physiologic abnormality there, with the, persistently increased sympathetic tone. There's also physiologic abnormalities going on in the gut with the enteric nervous system. So, there is a two-way connection there. And you have to think of treating gastroparesis as treating the whole person or all that innervates the stomach. And so if you treat the stomach in isolation without treating the sympathetic and the emotional trauma, then you're not going to be successful. But if you also only treat the PTSD, the anxiety, the depression, you're not going to make an impact in the stomach. And that trust is key. Like explaining, validating the symptoms, explaining the physiology or the pathophysiology as we know it, and then being there and supporting the patients. Those are all key factors there.
One of the things that we studied extensively was looking at whether or not, the way you described it, how could you not end up with anxiety or depression if you've been through this gastroparesis experience, you've been to hospitals, you've been to doctors, you've been sort of scoffed at, you've been disregarded, your experiences are being classified or dismissed, even by friends and family. There's social stigma, and there's also the loss of social engagement around food in a positive way. All of those things would lead a person to be depressed. The interesting thing that we found in the studies that we did, and we did it not just in this field, we did it in fibromyalgia, we did it in widespread pain conditions beyond that. What we found was that the diagnostic histories did not necessarily show that one condition preceded the onset of the others. So, because what we were looking for was to try to figure out whether or not there was one sort of index condition, something that was leading to the rest of the symptoms the way we were describing just now, where because of gastroparesis, you're going to have anxiety, you're going to have depression because of those things. It turned out that in just as many cases, the depression and the anxiety were actually diagnosed before the symptoms onset of gastroparesis or fibromyalgia or other things. And that suggested to me in particular that none of these things are index conditions in and of themselves, are actually a very widespread set of symptoms. Yeah, the underlying condition is really a nervous system dysfunction that is an imbalance in the autonomic nervous system that leads to that inflammation, leads to all of the experience, the perception of these problems.
Yeah, there's no question. It's a multifactorial challenge, and the underlying autonomic kind of state that a person is in is going to drive towards a particular direction.
In my simplistic view of it as a gastroenterologist, not a neurologist, when I think about the autonomic nervous system, it affects everything, right? From our sweating, pupillary dilation, all of the viscera, the motor, and the sensory components of it. And so if you have autonomic dysregulation or autonomic dysfunction, it can affect multiple systems. And in medical school, we're taught that, one person cannot have multiple diseases, the whole like Occam's razor type thing. And so when patients come to us with GI issues, with dizziness, with headache, with bladder pain, with fibromyalgia, dizziness, rashes, you start to think, well, how do I put all that together? It must be in their head. It must be psychosomatic. But the reality of it is all those systems are innervated by the autonomic nervous system. Of course, there's also the immune system too, but the autonomic nervous system also helps to regulate the immune system. So there's that interconnection there. And so, whenever I see a patient with multi-system involvement, my first question is, I start looking at their autonomic nervous system and then looking at their immune system. And there's probably patients with genetic predisposition. The most common one that I'm seeing these days is Ehlers-Danlos syndrome or type 3 EDS, which is a lot more common than we ever thought it was. JP, to go back to your question of how long I've been doing this, 20 years ago, I think I saw a rare patient with EDS, and now I diagnose at least one new patient a week. And so, I think we're learning, we are doing a better job of listening to patients, but there's a long way.
So one of the prior podcasts that we did was with a friend of mine who actually was a colleague for a short period of time. She's a nurse practitioner, and she herself has Ehlers-Danlos, and she has been using vagus nerve stimulation for a while now, and it has had really a dramatic effect on her life in many positive ways. Not just symptoms, but also she was able to get pregnant and have a child, and really a very normal, gestational period for her and for the baby. So it was something that was a big deal for her. So in any event, as you look at Ehlers-Danlos patients coming through your door, remember, that was an effective therapy. One other thing, and I want to I know this is a big point for Dr. Habib, is the microbiome and the importance of the integration of the gut health microbiome and its effect on the central nervous system. And so in these gastroparesis patients, do you see or even in IBS patients, do you see a significantly dysregulated microbiome and dysbiosis?
Yeah, we do see it, especially in irritable bowel syndrome, especially those with small intestinal bacterial overgrowth. The question always comes down to is what's chicken and what's egg, right? So what did a dysregulation of the microbiome lead to these symptoms, or are these conditions kind of inflammatory conditions that the inflammation is then disrupting the tight junctions and the microbiome? And again, I think you're going to find patients kind of in both, buckets or both categories, because we can't really simplify everybody into here's one mechanism of disease. So we do recognize that the microbiome is involved in these disorders. The question comes down to what do we do about it? Probiotics, I think, have variable effects in quote normalizing the microbiome and leading to symptom improvement, and even studies like doing fecal microbiota transplantation or FMT. We don't, other than recurrent C. diff infections, we haven't found kind of a role for that yet. There are things that we do know that can negatively impact the microbiome that we can that we can shift or we can influence. One is diet, right? So ultra processed, eating ultra processed foods, high sugar, the sugar additives, those are all things that can negatively influence the microbiome. But eating whole foods, like more of a Mediterranean diet or fermented foods, can increase the diversity. Sleep, we know that disordered sleep is associated with dysregulation of the microbiome. And so the microbiome, it's not static. It changes. And so when you do a stool microbiome test, you're really just looking at one snapshot that day that you got the stool. So it could be impacted by what you ate, the 2 days before you did that, or what your sleep was like. So we have to kind of look at it in terms of what are the static parts, what are the parts that are fixed, and then how can we influence that, whether it's through food, through probiotics, symbiotics, prebiotics, all those things that we still need to figure out.
when it comes to the microbiome with the stomach specifically. A really common thing that people talk a lot about from a practitioner side is H. pylori. Have you seen much of a correlation between H. pylori presence or infection and gastroparesis at all?
Necessarily, especially in the U.S., we don't see a lot of H. pylori, and in Northern California, I would say I see very little H. pylori. And of all my patients with gastroparesis, I would say a handful have H. pylori, or they've had H. pylori and treating it doesn't really make an impact in their symptoms. That being said, because it is considered a carcinogen, if you find H. pylori, you should offer treatment, not for the gastroparesis, but for the sake of H. pylori.
Certainly, yeah.
I was going to ask, because about sugar, you talked about highly processed foods and sugar intake having an impact on it. And maybe it's just because I finished writing a chapter of a book about metabolism. Do you see a shift in mitochondrial health? Do you see oxidative phosphorylation? Are you seeing more glycolysis? Are you seeing a shift away from, how does like a ketogenic diet where you're relying more on fatty acid burning than glucose, how do those play into, and has there been work looking at what mitochondrial health looks like in patients with gastroparesis?
Good question. We have not looked at it, or I'm not aware of that. In terms of metabolism or metabolic rate, we do observations. We do see an interesting phenomena in that about 30% of patients with gastroparesis have a BMI over 25, which makes you think, how can this happen if they have nausea, vomiting, and generally, when you look at the average caloric intake of someone with gastroparesis, it's between 900 and 1,200, kilocalories per day. So it doesn't match the energy in, energy out equation. And we started to do a study which ran into challenges because of COVID. Is we were looking at resting energy expenditure using like a metabolic cart and looking at the difference between what you measure versus what you calculate based on the current formulas that we have based on height, weight, activity, age, sex, etc., on what your caloric needs are. And in the patients that we were able to enroll, we found that there was a discrepancy between like their resting energy expenditure and their calculated caloric need. We also found in looking at their dietary intake that a lot of patients may have been calorie neutral in terms of they were eating the calories that they needed, but they were protein deficient. The majority of the calories were coming from carbohydrates. And whether or not that is contributing to the obesity or the weight gain that we're seeing, or could it be the medications? We don't know yet, but it's an interesting phenomena or observation that we're seeing, which goes back to adding stigma to patients, right? So if you have a BMI of 35 with gastroparesis and going into an emergency room vomiting, the looks that the patients get, that how can you have gastroparesis if your BMI is 35?
The tough thing to navigate, right? Because you've got this concept of metabolic syndrome and metabolic challenges being associated with overeating or overconsumption of calories, when in reality it may simply be the lack of ability to utilize those calories more effectively. And so there's more storage and a higher carbohydrate intake generally driving that. In a similar line, I'm intrigued by this concept of root causes. And there was one that I wanted to potentially bring up with you if you'd seen it at all, and that is the use of semaglutide as obviously diabetic medication / being utilized off-label for weight challenges. Have you seen any issues with gastric motility being reduced secondary to the use of semaglutide medication?
Yeah, so the whole class of the GLP-1 agonists do slow gastric emptying. And there have been studies that have looked at gastric emptying before and after. So in anyone that, is on one of these agents, I will take them off the therapies before measuring a gastric emptying test. Now, delaying gastric emptying and causing gastroparesis, those are different leaps there. Majority of the patients that, actually every patient that I've taken care of who is on a GLP-1 agonist and symptomatic, if you reduce the dose or stop the medication, the delaying gastric emptying goes away. I know there are people who have talked about stopping the medication and continuing to have gastroparesis or having it cause gastroparesis. We don't know, there's no case reports of that or why that would happen. If it's cleared the system, could these agents unmask something? And again, a lot of patients who are on these medications already have diabetes. So could this have been diabetic gastroparesis that was unmasked because you delayed the gastric emptying further than it had previously been delayed? Especially with the long-acting GLP-1 agonist, people have to remember that stopping means you have to stop it for at least 5 half-lives. And so for some of the longer-acting ones, where the half-life is 7 days, you're talking about 35 days of waiting. And so oftentimes what I'll see is they'll stop it for 1 or 2 weeks and say, oh, I'm still symptomatic. It must not be the medication.
Yeah, definitely not enough time to get a very clear sense. And that's an important factor to consider for any practitioners out there that might be listening to this. Why don't we shift gears now? We've talked a lot about root causes. We've talked a lot about things that drive gastroparesis potentially. Why don't we shift gears to therapies and tools that have worked in your practice that you are utilizing on a day-to-day basis? Why don't you let us know about a couple that, or a few that have stuck out as being very beneficial for patients that have suffered from gastroparesis?
I can't say there's any therapies that are very beneficial for gastroparesis. That goes back to the metoclopramide is the only FDA approved therapy for gastroparesis, and that now we're talking about almost 40 years of no new FDA approved therapies. So it means we do a lot of kind of trial and error in terms of treating symptoms. So anti-nausea medications for patients with nausea and vomiting, neuromodulators for abdominal pain, things like, low dose tricyclic antidepressant. But you have to be careful with those because they can further slow gastric emptying, gabapentin, pregabalin. Again, there's limited data on the efficacy of these medications. The vagus nerve stimulation is something that I do talk to patients about. We previously, there is a device that is the gastric electrical stimulator that is an implanted device on the stomach, but essentially it works on the vagal afferents, but it's implanted. Having non-invasive options for vagus nerve stimulation, I think, is something that patients are very much interested in, and physicians are interested in, because to date we don't know who benefits from this therapy. In our pilot study of 15 patients with idiopathic gastroparesis, we found that about 40% of patients responded to the therapy after four weeks. And we used a composite gastroparesis symptom index, score, and that if patients had at least a 0.75 reduction in their symptoms, we define that as response. So about 40% of our patients met that criteria. So we got 40% who improve, 60% who don't. So who are the 40? Who are the 60? Could the 60% improve with different stimulation parameters? So there's so much unknown there, but I think there's a lot of excitement and intrigue in this modality because of the non-invasive nature, and that we are potentially targeting, one aspect of the pathophysiology, which is the autonomic dysregulation that we do see.
So one of the things that has been pretty fascinating to me recently is the effect that vagus nerve stimulation has on mitochondria, which I don't think gets anywhere near the same press, if you will, that the effect that vagus nerve stimulation has on the immune system does. But it turns out that the same receptor, that alpha-7 nicotinic acetylcholine receptor that vagus nerve stimulation is so famous for affecting immune cells, is actually present on the surface of mitochondria. And that vagus nerve stimulation has the ability, through that same release of acetylcholine, to affect mitochondrial health and reduce oxidative phosphorylation. So it really is both incredibly intriguing, but also a little bit depressing that COVID interfered with getting that study done on metabolism and mitochondrial health in gastroparesis patients, because I think that might be maybe another clue as to what patients should be using vagus nerve stimulation as a treatment where the benefits will come, versus patients for whom the etiology of their disease is just different. So it would be wonderful if there were a way to sort of follow up with that study and continue that research, maybe in the context of looking at it as a sign for what patients should and should not be using various different modalities.
And that's an interesting thought. I'm going to have to sit down with that a little bit. We were looking at it more in terms of, can we impact symptoms by changing the diet to a more protein plant-based diet. And so that was our original intention. But in terms of looking at it from seeing which patients might be more responsive to vagus nerve stimulation, I'll reach back out to kind of play around with that idea a little bit more.
Okay, that sounds good. I appreciate that. Thank you.
Absolutely. In practice today, you generally utilize a few therapies. I know we talked a little bit about the study. We know it's a multifactorial issue. Gastroparesis is not a single factor that drives it. We know that there's idiopathic and diabetic sides to the diagnoses. We know that there's so many other buckets within that idiopathic frame as well. So when it comes down to it, what are some of the, let's kind of go with a simplified top 3, top 5 tools that you utilize, whether lifestyle-wise or otherwise, with your patients that have been suffering from gastroparesis?
Yeah, so I always start with diet and lifestyle. So things that can be modified. So, easily digestible, small particle foods, avoiding the ultra-processed foods, making sure, sleep, if there is disordered sleep, to work on that. And if they need to work with a sleep specialist, make the referral. And then, treating, the chronic stress, to tell someone to go live a stress-free life doesn't exist, but to really understand how you can mitigate the effects of chronic life stress on your system. So whether it's through, exercise, meditation, cognitive behavioral therapy, there's lots of evidence on gut-directed hypnosis in patients. Virtual reality is another way. So those are kind of things in terms of diet and lifestyle that that I talk to everybody about. And then with the other therapies, you go from, least invasive to most invasive, and then based on the severity of symptoms. And it's a partnership. And so, I talk to patients, about the different options. I don't go through the whole menu of options, but, at this stage of your symptoms and what you tried, here are a few options. What resonates with you? And here are my suggestions as to why. And whether it's medications, acupuncture, vagus nerve stimulation, it really depends on the patients, what their goals are. And the reality of it in our healthcare system is also what their financial abilities are. So, there's evidence that acupuncture helps, but acupuncture costs money. And so if you don't have access to a good acupuncturist, and if it's not covered by your insurance, it's not a resource or an option for you.
Yeah, that's fair. Obviously, patients need to be willing and be capable in every therapy that we provide. And I love that you're starting with a lot of the modifiable lifestyle factors that we know are in some way addressing or causing some of these challenges to begin with, whether it's dietary or stress management related. And so really glad to hear that is being taken care of in your patients. So that's really wonderful to hear. JP, anything to kind of finish it up and wrap up our call?
No, I look forward to following up on a number of different topics. Really great to reconnect. Appreciate all the work that you've been doing. And I look forward to the dialogue continuing.
Great. Yeah, thank you for having me. And I think, this is obviously a topic that is near and dear to my heart that I'm passionate about. So I could talk about this for hours. You all may get bored by the end of it, but I could talk on and on about food, digestion, and really more patient-centered care.
Absolutely. And it's been an absolute honor to meet you and to connect here, learn from you. Thank you so much for joining us. And for those who are listening and you got to this point, please share this with one person who you think you could utilize this information to help upgrade their health. Have a wonderful day.